Okay, good afternoon, everyone, and welcome to this month's Teach Educational Rounds. Here with us today, we have Marilyn White-Campbell and Dr. Aviva Rostas, who will be presenting on nicotine dependence in older adults. So I'll start off today with CAMH's land acknowledgement. CAMH is situated on lands that have been occupied for millennia. Lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of CAMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they were known at the time. Today, Toronto is covered by the Toronto Purchase Treaty Number 13 of 1805 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. CAMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis, and share the land and protect it for future generations. So now everyone is welcome to share something that they're currently doing to learn or improve their commitment to reconciliation, and also share which land you're joining us from today. So everyone's welcome to do that right now. In the meantime, I'll keep going with my own personal land acknowledgement. My name is Rachel. I'm a second-generation Canadian located on the lands of the Mississaugas of the Credit, which are covered by Toronto Purchase Treaty 13. I continue to listen and learn about the stories and cultures of various Indigenous communities and ensure that their voices are heard. So moving on, I just wanted to highlight an upcoming training that we have, the Teach Foundational Health Educator Workshop. And this is a 2-day in-person workshop. It's unique in that it's our only in-person workshop, and it is offered at the CAMH site and available to all learners. And so this workshop really will equip healthcare professionals with essential competencies needed for tobacco prevention and cessation. And it can be used to get the certification of the Certified Tobacco Educator or Certified Respiratory Educator. It's a prerequisite for both of those trainings, and they're offered through the CNRC. So if that's something that you're interested in getting, or if you're looking to upgrade your experience using that certification, then this workshop is a great stepping stone for that. So the registration link is on a QR code on the screen. And you're also welcome to reach out to teach@camh.ca if you have any questions. Registration is closing at the end of the week, but if this is something you're interested in and maybe you need a little more time or have some questions before figuring it out, again, feel free to email us and we'll help work with you to see what we can do. And continuing on, just a reminder that if you are interested in receiving a letter of completion for this Teach Educational Rounds, to make sure that you first registered for this webinar and completed the pre-learning assessment. And also that you signed into this webinar using your first name and your last name, and to complete the evaluation and post-learning assessment. And both of those will be sent to you at the end of the webinar. And so a bit about our presenters today. Marilyn White-Campbell is the geriatric addiction specialist with Baycrest's long-term care behavioral support outreach teams. She is the provincial lead for Behavioral Support's Ontario Brain Exchange Older Adult Substance Use Collaborative, which co-authored Cannabis in Older Adults, Know the Facts. Marilyn was a co-investigator with the Canadian Coalition for Seniors Mental Health Project, which established 4 national clinical best practice guidelines for SUDs in older adults. She is teach trained and is a strong advocate for smoking cessation supports in Ontario's long-term care homes. With over 38 years of clinical experience working with older adults with SUDs, she is recognized as a pioneer in the field of geriatric addictions. And Dr. Aviva Rostas completed her psychiatry psychiatry residency and geriatric psychiatry subspecialty training at the University of Toronto. She is currently on staff at CAMH and works in the geriatric psychiatry inpatient unit in transitional housing for seniors and consulting to long-term care homes. She is an assistant professor at the U of T's Department of Psychiatry. And I'll give you a moment to read through both presenters' disclosures. And this is just a note that all Teach Educational Rounds presenters are offered an honorarium. However, presentation content is not affected by acceptance of this honorarium. And please note that the content of Teach Educational Rounds are centered on evidence-based guidelines from the following sources. And nonetheless, these materials, as well as any verbal presentation and discussion, represent only general principles, and they do not remove the need for clinical assessments or treatment plans from healthcare professionals. So thank you everyone for joining. Thank you, Marilyn and Aviva, for coming today. I'll now pass it on to you, Marilyn, and we can get started with the presentation.
Okay. It doesn't seem to be moving forward. Oh, there we go.
Yeah, perfect.
Okay, so our learning objectives today is to discuss what's known about nicotine dependence in the older age group, identify evidence-based treatments for nicotine dependence and considerations for use in older adult population, and look at an approach to smoking cessation in older adults. So this is a case of someone that I've worked with. This is a 72-year-old male. He has a long-term history of smoking and other substance use disorders, and a recent diagnosis of frontal temporal dementia. So while he's living in the community, he had there were multiple attempts to support smoking cessation that were employed, including all types of nicotine replacement and vaping. And he was on the waiting list for long-term care. While waiting, he caused 3 fires in their apartment. So you know, that was quite you know, quite dramatic. And so what we did, we're going to go to the outcomes at the end of the slide after you hear what we have to say about supporting older adults with nicotine replacement and smoking cessation. So I'll hand that over to you. Is that you or me, Aviva?
That is, you can do it, Marilyn.
Okay. So tobacco is a primary preventable cause of disability and death in older adults. Older adults who smoke have doubled the mortality rate compared to older adults who do not smoke. Smoking is certainly risk to and linked to a higher risk of cognitive impairment and dementia in the elderly, and also has been associated with increased risk of macular degeneration, cataracts, hearing changes, and decreased abilities in smell and taste. Smoking is an important contributing factor to loss of function, mobility, independence, and fire-related fatalities in the elderly. Someone I met yesterday in a day hospital program said, I have to either stop smoking or I'm going to lose my legs. So because she had some vascular issues. Smoking is associated with age-related diseases in the elderly women, especially osteoporosis, breast cancer, cardiovascular disease, and has been shown to decrease physical strength and performance in this population. And older adults who smoke are highly nicotine dependent and less likely to believe that their smoking causes harms to their health. And these are the CanAdapt smoking report for older adults and smoking.
Okay, I can take over here. Thanks, Marilyn. So this is actually a little bit out of date. This is 2015. It's a graph looking at the prevalence, how common smoking is in different age groups in Canada. And the kind of relative numbers are still true. So if we look at the kind of 65 or older age group, in this graph, it's around just above 10%. I think now, if we look at more recent numbers, it's closer to 8 or 9%, which is lower than some of the other age groups. The peak is still in that kind of 50 to 64 age group. And this is, probably for a number of reasons, but a good reason being that many people who've been smoking for many years probably don't make it to that 65 or older age group. So this certainly affects the prevalence there. Next slide. And then Marilyn's already talked about, and this group I'm sure is familiar with all the negative health outcomes associated with smoking. So these are just some examples of kind of the top 8 causes of death in the world, and 6 out of 8 of them are related or can be related to smoking. So if you look at each bar, so for example, on the left, the ischemic heart disease, the hatched portion corresponds to the proportion of that disease that's attributed to smoking, right? So if we think about overall how much smoking contributes to death across the world, it's a huge amount. Next slide. Marilyn?
Okay, so how do we know when someone's in nicotine withdrawal? So the immediate onset is that somebody's got cravings to smoke. They'll say that they want to go to smoke. They get frustrated, they get angry, they may have difficulty concentrating and restless. And in dementia patients, it can be, manifest in wanting to leave the unit if they're on a secure unit. Or they may be saying, I want to go out, I want to go out, I want to have a cigarette, or they may be angry at somebody and yell at them. So those are some of the things that we see in older adults in a long-term care setting. And that can occur within a few hours of cessation, and it really peaks within 1 to 4 days, but it can last 6 months or longer. So it's not about the person, maybe they haven't been smoking for a few weeks or even 2 or 3 months, but the cravings can still be present. So in later onset, there can be nausea, diarrhea, and constipation. And we know constipation can be very challenging for older adults and can be a cause of delirium. Shakiness, dizziness, fatigue, sleep disturbances, headaches. And typically those are milder than immediate onset signs and symptoms, and they can, again, last 6 months or longer. So you need to consider in your assessments of behavioral and psychological symptoms of dementia, the person's tobacco use. When did they last use, or are they currently smoking? How often do they smoke? How much do they smoke? So quitting is a process. If you think about it, somebody who smokes a pack a day has approximately 110,000 hand-to-mouth repetitions every year. So if someone started at age 15 and at age 65, they've been smoking for 40 years. It's not easy. So if they had 25 cigarettes cigarettes a day for 40 years, that's 365,000 cigarettes and 4,380,000 hand-to-mouth repetitions. So at age 65, all of a sudden say, oh, you have to quit. It's not going to be easy. It can be very challenging for the quit to happen.
Okay.
So
if we think about kind of the profile of an older adult who smokes and what might differentiate them from a younger adult who's a smoker, older adults are often heavier smokers. So these are people who have often been smoking for decades, right? Like as Marilyn said, if they started when they're 15 and they're 70 now, it's been like many, many decades of smoking. They're often smoking like multiple packs of cigarettes per day. They're more likely to have chronic diseases because they've been smoking for many years and because of their age. They tend to be very, very highly nicotine dependent. And I think that's really the key when we start to talk about take-home messages later on. That's one of the key messages to take from this presentation, is to think about the degree of nicotine dependence in some of these older adults. And then when we think about, starting to support people with quitting smoking, in addition to all the other complexities that go into every case and very, very high levels of nicotine dependence, older adults very often, especially if they've been smokers, have cognitive impairment, right? So some of the things that we normally do, some of the techniques, the motivational interviewing, some of the things that require access to someone's thoughts just are not possible, right? So there are a lot more creativity is required. Next slide. Other differences, just like some medications are metabolized more slowly or differently in older adults, similarly so nicotine metabolism can be reduced in older adults. Very often older adults are less likely to be canceled to quit, right? So people might go to their family doctor for their annual kind of checkup, although they don't really do those anymore, but they go see their doctor. People get told, you should think about quitting smoking. That doesn't tend to happen as much in older adults, according to the literature. That being said, when an older adult does get support to quit smoking, some literature does show that they're actually more likely to succeed, right? And often their reasons for quitting can be different than what we might see in a younger adult, right? So we might see things like wanting to set an example for children or grandchildren or the younger generation. We might see motivations around housing, right? Being able to move into long-term care or another sort of facility that offers the support that someone might require. So we have to kind of think outside the box in these cases. And then I think, there's this widespread belief that at a certain point, it's just too late to quit. We'll hear people or their family say, it's their only pleasure left in life. They've lived this long. If anything bad was going to happen, it would have happened already. Or he's 80 years old. He's not going to change right now, right? And I think that's very much a myth, right? We have lots of evidence, which we'll get into a bit, but there's tons out there to show that there are lots of benefits to quitting at older age, in terms of increasing quality and quantity of life, and improving quality of life. So in terms of mortality, so this study looked at how many years do people gain when they quit smoking within different age groups. So if we look at kind of the top left, this is people who quit in that 25 to 34 age range. The bottom line, I don't think you can see my mouse, but the bottom kind of solid line is people who smoke, right? The top solid line is people who never smoked. And then the hatched line is people who quit smoking in that age range. So in the 25 to 34 age range. So in the youngest age range, people actually kind of reach the longevity of the never smokers. So on average, they'll gain 10 years of life compared to if they kept smoking. As the quit age becomes older and older, the years of life gained get smaller, right? But it's still there, right? So if we look at the 35 to 44, they gain, 9 years on average instead of 10, 45 to 54, 6 years on average, and even 55 to 64. So even a 63, 64-year-old on average will gain 4 years of life, right? And again, this is just in terms of quantity. This doesn't take into account quality of life, the improvement in all their chronic health conditions and other things that improve with smoking cessation. By around age 80, we start to see that there's not necessarily a gain in terms of years not lost. That being said, there still are improvements in terms of well-being and quality of life and chronic health conditions. So this take-home message is really important. Particularly, I know we're focusing on older adults today, but if you're seeing folks under 40 years old, right, it's a really important kind of message that, the younger you quit in this 25 to 34 age range, people gain 10 years of life. Their longevity approaches the never smokers. So really important, striking data. Next slide. And then similarly in terms of cognition, so Marilyn's already mentioned there's evidence out there that smoking increases risk of dementia. I think that's very well established. It's a vascular risk factor, just like having chronic hypertension or diabetes, right? But what we see is that when people quit smoking, it slows their cognitive decline. So this graph looks at people who are older, age 68 plus, who are smokers, and they were offered support to quit smoking. Some of them succeeded and some of them didn't, right? And they compared these people to the never smokers. So this graph's a little bit confusing, but essentially the vertical axis, the y-axis, looks at change in cognition. So the more steep the line, the more quickly someone's cognition is getting worse. So if you look at the green line, that's people who never smoked. With time, their cognition's getting worse, right? That makes sense. People are getting older. They're experiencing gradual cognitive decline. The red line is older adults who continued smoking. So, I wouldn't get too hung up in the ups and downs, but the overall trajectory is that their cognitive decline progresses more quickly. The line is more steep, right, than the never smokers. Interestingly, if you look at the blue line, so the successful quitters, again, focus on the slope of the line, the rate of their cognitive decline. It's actually quite similar to the people who never smoked. So quitting smoking, even in these people who are 68 plus, right, slows the rate of cognitive decline. And that, people might say, it's too late to quit. It's my only pleasure. People care about their brains. People care about their cognition. So that's also a very kind of handy tool, a handy message to be able to share with your clients. Marilyn?
So in terms of the assessment of the older smoker, the one thing you need to know is how many cigarettes per day is the person smoking, and that can be challenging with if the person is a poor historian, if their memory is poor and they're just smoking one after another, you may not have an idea of really how much they're taking in. But look at from the time they're waking up, when was their first cigarette? Some of them in a long-term care setting, it may be delayed. But if you ask them when they were home, when was your first cigarette? Some of them say, well, as soon as my feet would hit the ground. Before I would go to the washroom, I'd have a cigarette in my mouth. So looking at the time and the onset of the first day, the first cigarette of the day. And also looking at, do you smoke if you're so sick that you're in bed most of the time? That's often the case with some people. And then also, have they tried to quit before? And I will hear people say often, yeah, I tried to quit. I was in the hospital and then I had the patch on, but I still went out to smoke. Or the family members will say, well, I don't want them to go on the patch because when they were in hospital, they had the patch and they would still go out and smoke and they would stem for cigarettes at the front door. So, take those things into consideration when you're doing a smoking assessment.
Okay. So talking about, smoking cessation in older adults in general, for anyone, the literature supports combining medication and non-pharmacological, non-medication interventions, just like would be the case if we were talking about depression or anxiety or many other kind of conditions that we treat as mental health clinicians. When we think about cognitive impairment, it's tricky, right? We can't necessarily access people's thoughts. People don't necessarily remember. People can't kind of reason and have conversations in the same way, right? So we have to think more creatively. We have to think more about behavioral interventions as opposed to kind of cognitive or talking through interventions. And importantly to note, there are no clinical trials or guidelines specific to older adults, right? So we can kind of extrapolate what we can from the literature on adults in general. We can speak based on our experience, but none of this is kind of officially guideline based because it doesn't exist.
So there are some behavioral techniques. I think, Aviva, you worked with this particular home. I mean, if you think about it, you can use motivational interviewing, and that's really outside the scope of this presentation, but it's good to know sort of the basics. Using some relaxing activities, activities that can stimulate the mouth, the hand-to-mouth action, cold water, raw veggies, lollipops, and activities that can occupy the hands, so like knitting, jigsaw puzzles, cards, adult coloring books, things that keep the hands busy. And I think, Aviva, do you want to talk about your jelly bean experiment over at one of the homes?
Yeah, so this was many years ago, and I was a resident at the time, and one of the homes had great success with having kind of it's self-explanatory, a jelly bean jar, right? So when an individual would say, hey, I want to go smoke, the nurse would say, okay, sit down. Hey, do you want a jelly bean, right? It would keep their mouth busy. The sugar rush would give a bit of that dopamine hit, right? It wasn't obviously 100% successful in getting people to quit, right? But it often delayed. It often caused people to forget that they had wanted a cigarette. So it was a kind of easy, low cost, relatively safe. Obviously, we have to take into account people's chewing and swallowing, etc. But a really kind of simple and creative intervention that this home came up with. Okay. We'll move on to medications. So again, we're not going to talk about, medications overall, we're talking more specifically in terms of older adults. But the kind of main medications that we use in general for smoking cessation are NRT, nicotine replacement therapy, which comes, as I'm sure this group knows, in multiple forms, in patches, lozenge, inhaler, and a mouth spray. Bupropion, which is marketed as Zyban for smoking cessation, and varenicline or Champix. Next slide.
Well, and the one thing that we've learned that's sort of a homeopathic treatment that's available in Canada and now endorsed by Health Canada is cytosine. And the reason I'm putting this slide in is that after a while, if people are taking bupropion, varenicline for smoking cessation, I think there's a limited use. You can only have it for about 3 months. And so when that runs out, the person has to pay for it. So if it's an effective treatment, then having a backup. And cytosine is also known as bibixetone, and all these other names. I'm not going to bore you with them, or I can't pronounce them, is the reality. And it is an alkaloid that occurs naturally in several plants, such as the laburnum and the cytisus family of plants. And what happened is that during the wartime, the British soldiers, when they didn't have access to cigarettes, they would grab these leaves from the plant, from the laburnum plant, and they would chew it, and it would help with their cravings. So it is now being used to medically help with smoking cessation. The numbers needed to treat are 13 versus 11 with varenicline, so it's not a bad option, and it's much cheaper. If you have to pay for varenicline, it might cost you $300+, and for cytosine, it might be $30 to $60 per month. It is a little bit more of a challenge to administer because you have to take it a couple of times a day. But there's lots of information out there now, and it is being endorsed by the Ottawa Heart Health Institute.
So thanks, Marilyn. The only thing I would add about cytosine, I don't have experience personally, like having patients take it, but to be mindful in older adults, especially when we talk about kind of supplements or things that are purchased over the counter, to be mindful still of drug-drug interactions, right? So often to involve a pharmacist or plug things into a drug interactions checker online, because I think we often think these things are benign, and sometimes they are, but I think we have to think about this when our patients are on many other medications as well. So in terms of the kind of going back to the NRT, varenicline, bupropion, on-label medications, I suppose. They're all approved in Canada to be first line. Varenicline in the general population has the best odds of quitting. The literature is a little bit more mixed in older adults. So I actually did a bit of a deeper dive into this last night to make sure if anything was updated since we last presented on this topic. And it's actually, similar to NRT when we look at the studies in older adults. So very, maybe a little bit more first line in younger adults, but in older adults, not as clearly borne out, but still can be used in older adults. And really the idea is to have, give patients information about their options, and just like we would in any other situation, talk through kind of pros and cons and make a shared decision. Next slide.
Okay, so in terms of special considerations for use of a nicotine replacement, so first thing is dentures. You're going to be offering different types of nicotine replacement. So does the person have dentures? And so that means that gum is not the best option because the person may not be able to chew very well. You have to also remember to take the gum, chew it a couple times, park it, and then suck on it a little bit. And that can be challenging for cognitively impaired or people who have really, really poor impulse control. So what happens is they may put it in their mouth, chew it, and all at once, and they get a lot of nicotine in their stomach at once, and don't get the same desired effect of the nicotine as it would if they use the method properly. The inhaler is good for cognitively intact who can't chew, and it's really great because it emulates that hand-to-mouth motion associated with smoking. So people tend to really like that. It does have some side effects with mouth irritation and GI upset, but that's generally if people are using it too much. And if a person is cognitively impaired, they might not be able to express that they're having those GI upsets or mouth irritation. So, so you have to sort of gauge, is the person able to sort of understand and appreciate how to use the inhaler. And the other thing is when you consider using nicotine replacement with dementia patients, the Ottawa Health Heart Institute advocates for longer term use. And their motto is as much as it takes for as long as it takes. And oftentimes we see that, the nicotine patch has been, titrated down and the person is still having behaviors. So, and they may go back to smoking, or they may have some negative behaviors as a result of not having nicotine on board. So sometimes think about it, and using it longer term, as much as it takes for as long as it takes. So in terms of the nicotine mouth spray, I really liked the nicotine mouth spray. We had it available during the pandemic. It's a 1 milligram spray, and you can have a maximum of 4 sprays per hour. But I usually encourage just one spray. You spray inside the cheek or under the tongue. It can be a little bit quicker if it's at the very back in the corner next to the salivary glands. So, and it is something that's really very effective in cognitively impaired older adults. And it can be used to decrease agitation behaviors related to smoking. The only side effects are hiccups and tingling lips. Those hiccups go away within 2 minutes. So it's not a really bad side effect. You don't want to give the nicotine spray to somebody with cognitive impairment. You have to administer it. So it should be kept at the nursing station and administered on a regular basis. So if somebody is a pack-a-day smoker, then you may want to give them a regular sprays of once every hour or two.
And I just highlight around, the as much as it takes, as long as it takes. I can't tell you, how often I see patients coming into our inpatient unit at CAMH who, when I talk to them or their families about previous quit attempts, they say they were in the hospital last year for their whatever, for their stomach, for their heart failure. They got the nicotine patch. It didn't work, right? And when we explore a little bit more, when we talk about how much are they smoking, what dose of patch did they get, right? It just wasn't enough, right? It just wasn't enough nicotine. And we talked earlier about how often these older adults tend to be very, very heavily nicotine dependent, right? So, these failed attempts often need a little bit more kind of investigation to make sure they really were getting their nicotine withdrawal adequately assessed. And in my experience, often that unfortunately didn't happen. So in terms of kind of just going back to the previous, I never actually spoke about the last slide. So some, considerations when we're prescribing to older adults, just like any other medication we would prescribe, right? We have to think about, their health conditions, what other medications they're on, how are their kidneys and their liver and things that affect the metabolism and excretion of medications. For bupropion specifically, there's lots of literature using it as an antidepressant, but there's no specific literature looking at it for smoking cessation in older adults. For varenicline, there is some literature. It's generally considered safe. That being said, it is renally cleared. So in older adults with renal impairment, the maximum dose is a little bit lower. We have to be mindful of that. And again, it's not necessarily like the effectiveness is actually similar to NRT in older adults. So it might kind of lean us towards preferring NRT, at least as a first line. Next slide. And this is kind of going over specifically the dosing. I won't go over it in detail. This is generally for adults in general. Remember, specifically for varenicline in older adults, we have to be mindful of kidneys. Okay, so overall, this is, again, there's no guidelines. This is kind of from our experience, a general kind of approach to managing older adults and helping with smoking cessation. So when an older adult, is admitted to hospital or long-term care or rehab or any other sort of setting where they either can't smoke or can't smoke exactly when they want, as if they would, in their own home, no matter whether or not they plan to quit or agree to quit or whatever the story is, it's important to help them manage nicotine withdrawal. It's going to be uncomfortable. It's going to make them agitated. It'll cause quote unquote behaviors, right? So again, even if someone doesn't want to quit, we can still use NRT. We still should use NRT to assist with nicotine withdrawal. Behavioral interventions are important to be used together with other things, but we have to be creative, right? We can't just use the counseling or MI that we might use in a more general adult population. That being said, most older adults will require some sort of pharmacological intervention, be it NRT or one of the other medications, because of their heavy degree of nicotine dependence. Next slide. In older adults, NRT is the best studied. And in general, we'd start with the patch first, right? We'd get a sense of how much they're smoking, by, of course, asking them, right? Which may or may not lead to a reliable answer, but also just a sense of how nicotine dependent they are. So when Marilyn spoke earlier about assessing the older adult, someone who wakes up and has a cigarette, within 5 minutes of waking up, that tells you about a degree of nicotine dependence. Or someone who smokes, even if they're stuck sick in bed all day and they still have their cigarettes on those days. All these things will tell you about the degree of nicotine dependence. And in terms of dosing the patch, right, in general, there's, rough numbers, but the 21 milligram patch would very roughly correspond to kind of someone who smokes 1 pack per day. And we'll often see, very often see our older adults needing, they'll say, I was on the maximum, I was on 21 milligrams and it wasn't enough. You can combine patches, right? So you can slap on a 21 and an 8 or a 21 and a 14 or even 2 21s, right? If somebody's that nicotine dependent and that's what they need. And then we'll add on the short-acting NRT as a PRN. So if we think of the model of, I like to kind of compare it to managing pain, right? Where someone might have their, their hydromorph content or something that's dosed twice a day, every 12 hours, and then short-acting hydromorphone for, breakthrough pain. It's a similar model, right? So they'll have their nicotine patch on and then a short-acting nicotine, the spray, the inhaler, the gum, whatever it is, as their kind of PRN agent. Next slide. And again, kind of take home points. So in general, when we think of prescribing for older adults, we say, older adults, we have to go to a lower dose. Maybe that's true for varenicline, but I would say that's probably not true for NRT. In fact, older adults will often need higher doses because of their degree of nicotine dependence. NRT can be used and should be used even if there's no long-term goal to quit smoking, right? It's really important, no matter what, if someone's in a place where they can't smoke as they normally would, to address their nicotine withdrawal. Next slide. And then very briefly, smoking is metabolized by one of the liver enzymes. I think it's called CYP1A2, which doesn't really matter, but basically what cigarettes do is they make this enzyme work more quickly. So medications which are metabolized by this enzyme, then smoking lowers their levels. So for psychiatric medications, I'm a psychiatrist, so this is what I kind of think about the most. If we see older adults on clozapine or olanzapine, so these are common antipsychotics, when they're smoking, the levels of the medication are lower. This is important because if they then reduce how much they're smoking or quit smoking, the levels of the medication goes higher, right? So we have to think about potentially reducing doses when someone's quitting or reducing smoking. Similarly, there's some kind of literature coming out around cigarettes affecting the pancreas and insulin regulation, right? And we actually find that medications for diabetes tend to work a little bit better when someone quits smoking, right? So if someone's reducing their smoking or quitting smoking, they might need less of their diabetes medications. And if we're not keeping a close eye, they might fall into a state where their sugars go too low, right? Warfarin, I think we're seeing less and less people on warfarin in general as newer kind of anticoagulants come out. But if somebody is on warfarin, we need to keep a very close eye on their INR as they go through a quit attempt.
So we'll just talk about what happened with Mr. C. So knowing what you've heard just now, what did we do to support Mr. C? So he was living in the community, and we had the PSWs coming in and applying the patch daily, and we had noted he complained that he had some skin irritation, so he declined to use the patch. So it worked for a little bit, and then he said, no, I don't want to use it. It's making my skin itch. So we gave him the nicotine lozenges, and that was problematic because he couldn't remember to suck on it. He wouldn't get the right dose. He would chew it and swallow it, and he was not getting the right dose of nicotine. So he returned to smoking almost within a week. The use of the nicotine inhaler, he did find it helpful, but he didn't remember to change the cartridge. And so as soon as the cartridge was out, he would puff and not get the effect. And so he'd go into nicotine withdrawal and seek out a cigarette. So, you know, for people who are cognitively impaired, they need somebody to change that cartridge regularly. We offered the use of candy, and actually when he was on the unit at the hospital, he was given a day pass, and he went out and he bought some candy and like $90 worth of candy at the Shoppers Drug Mart, and he came back to the unit and he consumed it all over the weekend and ended up with diarrhea. So just again, really poor impulse control with this fellow. We used the vape. But again, he was not able to self-regulate his smoking. He was constantly puffing on that thing, and that actually increased his intake. The nicotine inhaler we bought one just for, you know, cost effectiveness. We bought one that had 10,000 puffs in it. And that should have lasted him 3.5 weeks. And that would be based on a pack a day for, you know, every day for 3.5 weeks. And he went through that vape within 3 days. So that's a lot of nicotine. So, and then what happened due to his cognitive decline and being at risk for fire in the community, he was eventually moved to long-term care. He had 3 fires. So that was what precipitated the crisis placement to long-term care. He just really didn't understand and appreciate the risks. And he would, you know, light a cigarette and have, you know, flammables beside the ashtray or in the ashtray, or he put the cigarettes or the ashes in a waste paper bin with flammables in it, and so he did have 3 very serious fires. So now that he's in long-term care, nicotine replacement is given at specific times, and we're using lots and lots of behavioral techniques. One of the things that's been successful, some of them have not been successful, but we gave him the nicotine inhaler, and so it was given to him on, you know, for about 15 minutes once an hour throughout the day. And so we also added the use of a rubber straw, and that was really good because it helped to address the hyperorality. We put some signage in his room to remind him of those 4 Ds that are associated with smoking cessation. So delay, distract, drink water, and deep breathing. And if we reminded him, if you went into the room and you reminded him, then he would do that. He always kept a bottle of water beside him, and he would do some deep breathing. And the other was to use a tablet for video viewing, and he went to some online meetings. He's not happy being in a secure unit, but he readily admits that if he had the opportunity, he would smoke. And we know that because of the risk for fire, that is really a serious concern. So this is a video. I'm going to set this up. This is a video of someone living in long-term care who actually had a successful quit attempt. And I'll just tell you that I'll let you see the video, and then I'll explain later if you don't hear it properly.
This guy that's in that works in the building, he goes outside and smokes. Every time he passes by me, I can smell him, right? I can smell his clothes, I can smell the thing. And I told him, I said, you smell like an ashtray. He looked at me and said, I do? I said, yeah, your clothes. You smell. I mean, I can smell it. And that's the way I used to smell too, because my friend told me the same thing. It would be maybe a trigger for somebody else, not for me. I don't think so, because it's been so long for me.
So this is somebody who actually needed more nicotine replacement, and he was on a 21 milligram patch and would still continue to smoke subversively in his room. And then when we added a 7 milligram patch, so he's up to 28 milligrams, he was fine. and that was the magic number for him. And he continued to abstain from smoking. The other really important message for this person as well is that he had a very serious stage 4 wound, and that wound literally healed up, and he had that wound for over 4 years, and that wound healed up within 6 months. So there's some benefits, even if it never adds to someone's length of life, certainly quality of life, because he had complete healing of that stage 4 wound. The other thing is that we have the Stop in Long-Term Care program, and I'm going to put this up so that you can take a picture of the QR code or the URL code here. We have a program called Stop in Long-Term Care, and it's available for no cost nicotine replacement for all residents of a long-term care home in Ontario. The program is you have to sign up for it, and I think Carolyn Peters is online here, and you could be in touch with her. And you can scan this code, and it'll take you right to the website. And the program is also available to the staff. And if you remember seeing this gentleman saying, every time I passed by, I could smell the cigarette smoke on this person, and they smelled like an ashtray. So it can be very triggering for somebody who is receiving care who can't smoke. So if someone broke a hip and they can't go out for 6 weeks, they're stuck in bed, then having somebody come in after they've had a smoke break, that can be very triggering and very upsetting for them. So that's the end of our presentation. So I guess we've got a few minutes for questions.
So Marilyn, there was a question. With the medication interactions, do we see similar effects, like more meds in their system or more caffeine, etc., when people reduce but not fully quit smoking? For example, down from a pack a day to, say, 5 cigarettes or less a day.
So I can try to answer that. So I mean, I think the truth is we have to monitor, right? I think if we know someone's reducing how much they're smoking, and they're taking a medication that where the levels can be affected by smoking cigarettes, we have to monitor. So in my practice, the classic example would be clozapine, right? We would monitor clinically if somebody seems to have signs or symptoms of having too much clozapine in their system, like seeming sedated or dizzy. For medications where we can monitor drug levels, we can do that as well, right? So I think, yes, the message is if someone is reducing how much they're smoking, we certainly have to monitor those medications where there's an interaction.
Thank you. Let me see if there's anything else. Oh, in the long-term care home, I think this is for Stop specific, but I wonder if the next wave of smokers will consist of more vapors. If this is the case, how would your strategy or approach for treatment for nicotine withdrawal and cessation be different?
Well, certainly my experience with vaping is that if the person is at risk for fires and they're in the community, then a vape is less harmful, but not without harm than combustible tobacco. So if you've got somebody who is at risk of having a fire, then maybe vaping is a good option for them. When they transition to long-term care, then it would be a time to look at using nicotine replacement, especially if they're going to a secure unit or they can't go out unsupervised, because you certainly cannot use a vape inside any building. So that's something to take into consideration.
The other thing I would add about vaping, I mean, certainly nothing is safe, right? Nothing is 100% safe, right? There are certainly some ways in which vaping may be safer, right? In terms of fire risk and perhaps some of the other serious safety concerns that go along with cigarettes, but they're not benign, right? So I saw a recent study around, there's actually potentially a link between heart failure and older adults who vape. I think we're always thinking about of all our approaches, what is the safest one, right? And vaping may be safer than continuing to smoke cigarettes, right? But NRT may still be safer than vaping, right? So it's not it's kind of a balancing our options and looking at what makes sense in a particular case.
Thank you. There was another question, can we combine NRT and vaping in old adults to quit smoking?
So, can you combine NRT and vaping? Again, is the person able to sort of understand and appreciate? You don't want the person, if they have cognitive impairment, you don't want to increase their nicotine levels. So, do it cautiously as a measure to make sure that they're safe from not having a fire in the building. So, the answer is yes and no. And they shouldn't need both, but if they do use both, there's no no sort of formula for it. I have had people when they run out of cigarettes, then having the vape is handy. The important thing is that you want to manage the withdrawal, and I see a question in there about withdrawal from nicotine. You want to make sure that the person is comfortable, and that's the whole premise behind offering nicotine replacement to someone living in a long-term care setting. Is if they can't get out, you want to make sure that they're comfortable. And we did use a lot of nicotine replacement during the pandemic when people were not able to go out to smoke. And it was very, very effective. And in fact, that's one of the reasons we have the Stop and Long-Term Care program, because there were so many residents in long-term care who benefited from it. We were having lots of issues with people smoking subversively and going out to smoke during lockdown. So using nicotine replacement was the thing that really helped to settle people and keep them in quarantine.
The other piece I hope we mentioned it in the presentation, but I think we might have forgotten is, this idea around if somebody smokes a cigarette while they're on NRT, right? And I've seen cases where someone's on NRT and they still go out and smoke a cigarette, and then the immediate kind of reaction is to discontinue the NRT and say it's A, it didn't work, and B, it's dangerous, they're smoking on NRT, right? There's no, just like when we talk about, the vaping with NRT, again, there's no formula around smoking on NRT, right? And if somebody's continuing to want cigarettes and to crave nicotine, the initial thought I would have is, are they getting enough NRT, right? Are they still experiencing nicotine withdrawal and maybe need a higher dose of patch or more availability of the short-acting PRNs, or a little bit of both, right? But somebody having a cigarette while they're on NRT is absolutely not an immediate reason to say, let's stop the NRT, right? It's a reason to kind of rethink our approach.
Yeah, to echo what Aviva was saying, is that we actually have some residents who are on a 21 milligram patch and have 3 scheduled smoking breaks where they have to have supervised smoking because it was the residents' wish to have continue to smoke, but on a limited basis. And because they were a risky smoker and had a fire, which sent them to the hospital, to the burn unit, they really needed to be careful to make sure that she was safe to smoke. So it was supervised 3 times a day, and she was quite happy with that, and she continues to do that to this day.
Thanks. There was another question on what your thoughts are for giving prescribed NRT to manage withdrawal to achieve better sleep and possible improved cognition.
Well, actually, one of the things that I like about the nicotine inhaler is you can leave it on the bedside, and as long as the person knows to keep it safe and not let other residents have it, you can leave it on the bedside, and they can have a little pull on it, in the middle of the night if they wake up and they are in nicotine withdrawal, or if they can have a little, a few puffs on it before they go to bed, and that will help them to not wake up through the night, because some people who are very, very heavy smokers will get up in the middle of the night and want to go outside, and in long-term care, that's not always possible. So yes, you can use it to help with the evening routine. The one consideration with the nicotine inhaler in the long-term care is that sometimes people lose that little plastic inhaler piece, and so I recommend that you take that the inhaler, wrap a piece of Scotch tape around it with a string, Scotch tape, not the heavy duty tape, so that it releases easily if it gets caught on something. But if somebody has it around their neck, then they won't lose it, and they can use it whenever they want. Does that answer the question?
Yes, thank you. I think we have time for one more. And I saw one. Have you found that the aggression or incidents related to thwarted nicotine dependency to long-term care staff have declined in their number or severity?
Well, that's the one thing that we did notice during pandemic, is that as long as people were comfortable, then they weren't acting out. They weren't trying to elope. They weren't trying to leave their room, and they weren't having behaviors towards staff or other residents. So we had a number of residents that were referred to me because exactly those things were happening. They were going after other residents. They were yelling and screaming and striking out at nursing staff. So as long as their nicotine needs are met, it can reduce those behaviors.
Perfect. So I don't know if you saw the chat, but there were a lot of questions saying thank you for the presentation and how engaging it was. And I agree. Thank you both so much. I think we're out of time today for questions, but I'll leave their emails on the slide here, Aviva and Marilyn. So you're welcome to reach out if you have anything. These will also be sent to you at the end of the webinar. And I'll also include the contact info for stop in long-term care homes in case anyone's interested in that. And this is just a reminder that the evaluation and post-learning assessment will be emailed to you, and you'll have a week to complete that if you're interested in receiving a letter of completion. And our next Teach educational rounds will be a special Roberta Ference lecture on brainstem and smoking cessation, and that will be next month on September 24th with Dr. Victor Tang. And registration will be opening for that soon in the next couple of weeks. And if you missed a portion of today's webinar or would like to view it again or any of our previous webinars, you're welcome to check out the archive list on the Teach website. For now, thank you both. Thank you, Marilyn. Thank you, Aviva. Thank you, everyone, for joining. And I hope you enjoy the rest of your day.
Thank you, everyone.
Thank you. And if there are